dun, dun. Excellent. So, good morning, everybody, and thank you, Dr. Kit Byatt, for joining me this morning to talk all things geriatrics and anything else really that sort of, takes your fancy. I think, you briefly mentioned to me this morning you've got some issues with powers of attorney, which, always fun. So, yeah, lovely. So I'm Heledd, I'm from GL Law, and Kit, over to you. Would you like to tell us a bit about yourself?
Thanks. Actually, I had prepared myself to be cross-examined rather than give a presentation. But I grew up in Chester, and I went to London to university and graduated there and did my early postgraduate, well, most of my postgraduate training in and around London. And then I got my first consultant appointment in King's Lynn in Norfolk in 1990. And so we moved up to northwest Norfolk, and the Wash, which is where I found out that the Wash is the west coast of Norfolk is the only place where you can see the sunset over sea on the east coast of England or Britain.
Oh, yeah. It's incredibly flat over there. As somebody who's from North Wales, I went to see a friend who lived in Wisbech, and I got there and went, okay, I'm almost claustrophobic or agoraphobic, or
Well, I'm going to challenge that assertion in that although Noel Coward said Norfolk terribly flat, in fact it's Cambridgeshire and Lincolnshire that are terribly flat. And northwest Norfolk, they're actually in Hunstanton, there are cliffs. They're not very tall, but there are cliffs there about I can't remember exactly how tall, maybe 30 meters or something. And the land from northwest Norfolk down to east Norfolk, where the Broads are, which are flat, is undulating. So if you ever try cycling from Hunstanton, which is at the top left-hand point of Norfolk, down to King's Lynn, which is the bottom of the Wash, I've not done it all, but it's undulating. You notice they're small, they're slopes. I mean, compared to Wales, they're nothing, but it's not, northwest Norfolk isn't flat, and that's where Sandringham is, incidentally. So one day when my wife was driving along the main road there, a Land Rover had to give way to her coming out of one of the side roads, and the Queen was driving it. So my wife was very pleased to have.
Oh well, fair enough. So anyway, there we are. I digress. Yeah. We digress.
I worked in King's Lynn as a general physician and geriatrician. So I was part of the general acute take. I was seeing all the medical emergencies coming in on the rota each day, and I also had looked after my own older patients with rehabilitation problems. And back in those days, we did domiciliary visits. If asked by GPs, we'd go and review people in their homes. And in fact, that was, as I say, in the early 90s, it was a great way of getting to know each other. When you first went to work in a place, the GPs would ask you to come see a patient with them, and you'd spend maybe half an hour with them and the patient in the patient's home. So you'd get to know the GP, and they would get to know you and your foibles. And it made it, you knew who you were dealing with. Whereas now, domiciliary visits, which we got paid for doing, we had to fill in the form, got paid for doing them, but they became increasingly unused because of the time taken for the GPs, and the consultant. And so I was doing, I think, something like one a week probably initially, but they gradually tailed down to, by the time I left King's Lynn to come to Hereford in 2001, I was doing maybe one or two a year, I think. And I did a few when I came to Hereford, again, probably just to meet some of the older GPs for whom this is a tradition. But for the last 10 or 15, when I was in Hereford, I've been in Hereford since 2001, retired 2016, so it's 15 years. I guess 16 years, 15 years, whatever. For the last 10 years that I didn't do any domiciliary visits, which I sort of regret, really, because seeing people in their natural habitat is critical. We're all different. I mean, having read some work by anthropologists, it's fascinating looking at people from sort of objectively, not projecting one's own values and hopes and aspirations and preferences on them, but seeing how they live their lives. And I remember once there was I was at Charing Cross Hospital Medical School, and there were some really eccentric consultants there. one of whom was always nibbling the end of his tie. That was his sort of go-to habit. And another one, a senior consultant, who was an endocrinologist, who's Batty, he said, it doesn't matter if you put he said, most people put their shoes under the table and their hairbrush on the dressing table. He said, if someone chooses to put their shoes on the dressing table and their hairbrush under the table, it doesn't matter. You know, that everyone does their own thing. And that him saying that stuck with me. I mean, also, I remember him telling me he taught the other guy who nibbled his tie, who was a very sort of intense academic person, who eventually became the professor of medicine, respiratory medicine. And the endocrinologist tells the story of being in a lift with Abe Guz, this professor to be. And as they got out of the lift, Abe Guz was chewing the bottom of the other guy's tie. He picked up the wrong tie. And he's the typical absent-minded professor who was showing someone around his department and showing him what's called a body box, where a person sits in a big sort of wooden box with glass panels to do breathing tests. So all everything they breathe has to come in and out through a tube in the side of the box, so it doesn't mix with room air. So everything can be measured. And he was demonstrating this to someone, and then wandered off somewhere else. And then only a while later, remembered that he'd left the guy shut inside the body box.
Gosh.
Anyway, sorry. Those were the days, really.
I think there's a fine line between this sort of eccentricity and madness, and that sort of and clinical madness is another thing again, isn't it?
Well, it brings us back really to the point that, I mean, one of the key things in geriatric medicine is that we're dealing with individual human beings. And another professor of geriatric medicine, whom his name, his book's there somewhere, who was also a philosopher, a professor in Manchester. The name will come back to me. Ray Tallis, that's right, Professor Ray Tallis. He's written various books on philosophy as well, and he's a poet and sort of polymath. But I remember at one lecture that he gave at the Royal College of Physicians about some aspects of geriatrics, he came up with this epithet that diversity increases with age. So things become more, rather than people ever becoming more similar, or everything becomes more disparate, if you like. And so the point is that as we get older, we change in our, some of our thoughts and beliefs become entrenched, and attitudes and behaviors. But quite often people lose some of their inhibitions or their social not wanting to make a fool of themselves, or whatever. They've reached the stage where they know who they are, they're confident in themselves, they've made up their mind about how the world works and what their place is in it, and they just say what they think rather than being polite. And I'm not saying everybody does that, but it often happens. So I think I learned fairly early on, I think, that people, well, actually, one of the things I went into medicine for was because I was fascinated by human beings and what makes us all tick, and whether everybody else was just as weird as I was. And it turns out that we are all as weird as each other, really. We all have our own little things that we do in private that we hope no one ever hears about or sees, or not many people. And we all have our public persona. And in fact, my experience is, and I don't think I'm alone in that I have several personas. I have my professional persona, and I have my personal persona in different contexts, family, whatever. And yes, there are some common threads that run through all those different facets and all those different contexts. But to try and define someone by a 30-question cognitive assessment test is so reductionist in some ways that it's almost an insult. I mean, it's a useful tool in certain circumstances, but we have to be aware of what the tool's being used for, in what context and why, and what its limitations are. And one of the fundamental laws of medicine is that no test is perfect, and that we always get false positives and false negatives and uncertainty around an answer. And the last 2 years have really shown us in spades just how difficult it can be for us to deal with uncertainty and to deal with lots of quantitative information. particularly when it's estimated or projected or suspected, and how easy it is to take figures and play with them and end up making very extreme inferences or assertions based on very little evidence.
Yeah, I think that's such an important aspect, that it's about people, as you say, it's about people, and you meet people, and you got your checklists, and you sort of go through them, and they do serve a purpose, and we do the same thing when we're talking to our clients. But it's all the stuff that's not said, it's all the stuff around, it's all the stuff, the quiet stuff, and the stuff around the edges, and it's that ability to really get to know somebody. And it often it's time, isn't it? It's just needing that time, whether it's repeat time or time for that first meeting, to really get to grips with that person.
Well, I mean, that immediately makes me think of two key things, really. One is that time and again, both doctors and patients, if you ask them or if they think about it, will say that one of the most important things is continuity. That if I see a patient once each day for 10 days, and yes, I spend a lot of time initially getting to know their case and the key features of it, if you like, and the key pointers in that with the problem that they have, then the next day I can just check how they are compared to yesterday. From the end of the bed, I can see how they look a lot better, or they look a lot worse, or they don't look much different. And the difference between my seeing a patient once a day for 10 days versus 10 doctors each seeing that same patient once a day each is just, it's almost immeasurable, really. It's so much less efficient to start from scratch each time, and it's so frustrating for the patient to have to tell the same things over again each time, try and remember what they said the last time. And the risk of, I mean, one of the things that trying to document stuff accurately is obviously critical. And if you know if you saw the person last time and you wrote down your thoughts, we only ever write down a percentage of what we think. We write down what we think are the key bits, but there isn't time to think through all the thoughts. I considered this, and what about that? No, I once saw a case like this. Could it be like that? And have discussions with other members in the team. Yes, we try and capture the essence of the case, but by definition, it's always partial, and we are all full of cognitive biases. And we all the confirmation bias is a terrible thing. Someone, I can't remember who it was, once said, experts very rarely prove themselves wrong. And a lot of specialists and experts spent a lot of time following a particular hypothesis or a belief, trying to build up evidence in a given field. But the Popperian model of science is that experiments are designed to try and disprove hypotheses, and it's only once you've done loads of different tests to try and disprove it and they've all failed, then it becomes an accepted principle. But often in diagnosis, when someone says, "Well, I think this might be pneumonia," as soon as someone writes in the notes, query pneumonia, or working diagnosis pneumonia, or suspecting pneumonia, then everybody's thinking, oh, it's probably pneumonia, because someone else has done the thinking for them. And then they look for evidence to confirm that, rather than thinking someone thinks it's pneumonia, but there's something here that doesn't quite fit, or are we sure it's pneumonia, or on what basis was that diagnosis made? And unless you know who made the diagnosis, I mean, if a professor of respiratory medicine, whose specialist expertise over the last 30 years was researching pneumonia, and they say this person got pneumonia, well, then they've got pneumonia. But if a recently graduated doctor sees their first patient and hears some sounds and says, I think this is pneumonia, they put down suspected pneumonia, then a nurse sees in the notes suspected pneumonia, and they ring up someone, there's a patient here with pneumonia. And in fact, the noise in the lungs was due to fluid because of heart failure, and it was misdiagnosed. Then it's not difficult to see how things can go horribly wrong. And so that there's a balance to be struck in that continuity is brilliant, but discontinuity has its place in the sense if a fresh set of eyes comes along, or a fresh brain looks at the evidence on the table and says, well, you've tried to fit this square evidence into that round diagnostic hole. What about this square diagnostic hole, which seems to fit better? Asking key questions, challenging things, ideally gently and diplomatically. because a lot of egos flash, sort of bouncing around. Um, for me, one of the reasons I went into hospital medicine was because I felt far too insecure and unconfident to become a general practitioner, having to deal with geriatrics, pediatrics, medicine, psychiatry, obstetrics, gynecology, dermatology, the whole gamut, by myself in effect. Whereas if I worked in a hospital, I'd be just focusing on one bit of that, and I'd have lots of colleagues around me on whom I could rely to make up for my own deficiencies. And I take my hat off to general practitioners who see 90% of, or do not have 90% of patient contacts, and on 10% of the budget, the NHS budget, and with a fraction of the tests and expertise in any given area that secondary care physicians have. I put most secondary care physicians asked to do a GP surgery would crack up after not very long at all, because there's so much non-specific stuff. Is this someone who's anxious, or is it someone who's got cancer, or is it someone who's anxious because there's something not quite right with them because they've got cancer? There's a lot of worried well people about. There's a lot of people who've got minor illnesses who think they may be more severe, and there is a proportion of people who have serious illness. And if GPs miss it, they get pilloried. But equally, if they over-investigate people or over-refer people, they get hounded by their commissioners and auditors and so forth. So. And that's with 10% GP posts roughly unfilled, and the numbers of GPs having been static despite the 5,000 extra promised by the previous Secretary of State, and sorry, the last but one Secretary of State, Jeremy Hunt, and demand rising by 10%, I think, over the last year or two. I mean, it was rising before the pandemic, and obviously the pandemic has sort of blown things apart in a major way. And again, taking my hat off to my GP colleagues, they've responded amazingly. That they're at the forefront of the complaints because it's difficult to get GP appointments. But when you've got fewer slots because of having to be careful about infection control, and 10% unfilled posts, and demands rising, and having changed how they practice dramatically, and being pilloried in the press, and even by and not defended by the Department of Health when the Mail was complaining about GPs not seeing enough face-to-face patients, and raising a campaign saying we must see face-to-face patients, without thinking that there are lots of things where patients prefer to do things virtually. It's easier, more convenient, and perhaps more private than saying to the receptionist, "Oh, I've come to see about I want a vasectomy," or whatever. And the whole of the waiting room here is what it's all about. And that's not long after the Department of Health launched a thing about trying to get GPs to do more video consultations. Yes, so yes. The GPs are sort of getting hit on all sides. And then on top of all that, they deliver a however many million dose vaccine campaign incredibly efficiently, compared to a £37 billion test and trace service, or so-called service set up by Serco, that has failed to deliver and has been, according to the Health Select Committee, useless. So anyway, I'll get off that particular soapbox. But where was I? Yeah, I was talking about continuity and knowing the person. And in a way, that's the essence of certainly medicine, and I guess law, a lot of law, that if you know your patient and if they know you and if you trust each other, then you can do a lot of business really very efficiently. The whole thing about dementia and delirium, where delirium is a temporary upset in one's thinking function, so that one isn't thinking properly, either disorientated or frightened or hallucinating or whatever. The brain is malfunctioning on a temporary basis. And people with dementia are much more prone to developing episodes of delirium, delirium is often called confusion as a sort of lay term, but it may manifest itself. There are different types of delirium. hyperactive delirium, where the person's agitated and looking around and playing themselves and seeing things and whatever. And there's hypoactive, i.e. slowing down delirium, where the person just curls up in a ball on the bed and withdraws. And the latter is often much more, obviously, more often missed. And I remember, over my career, seeing endless times in the notes pleasantly confused, where, in other words, they're confused but not causing us a problem, so we don't have to worry about them. And in fact, we now recognise that delirium is a medical emergency, that it means that something has triggered that delirium, something has caused that change from that person's normal state. Sometimes it's a major thing like a stroke or an infection or a heart attack. Sometimes it's a minor thing like just a change in the routine, a different person, different carer coming in, and the person who's not expected, or the person becoming constipated. And I love detective novels. I'm a massive fan of Sherlock Holmes. He's my sort of idol, really, for logical thinking, analytical thinking, and deduction. I mean, one of the things I love reading detective stories and sort of thrillers and things, trying to work out what's going on. And for me, each patient is a diagnostic challenge and also a human challenge. The diagnostic challenge is what's going on, what can we do about it, and how can we get them better. And the human challenge is how can we help this person steer their way through the illness journey that they're on, and help them manage it as best they can. And I mean, one learns that one's preconceptions are, going back to the anthropology thing, that one has to put one's preconceptions to one side, and one's enculturation, or one's, how things happen in a given culture, or how we like to think they happen in a given culture, and start from scratch almost with each person. And if that person normally does things in a certain way and then starts doing things in a different way, then you have to say, well, what's made them change? Maybe they've heard something on the radio saying it's more efficient to do whatever it is this way, or maybe their brain is temporarily or beginning to be permanently malfunctioning, and what they used to do, they no longer can do because the bit of brain that they depended on to do it didn't work. I mean, an example of that is my own mother. She developed well, it goes back before that. Another really important principle in Japanese medicine. My parents lived up in Chester, and my mother and my father lived perfectly well. He had been a teacher, and she had been a teacher, and latterly a local councillor and ultimately mayor, and had worked hard for the city on the council. Anyway, my father one morning, I got a phone call. I can't even remember who it's from now, but he'd fallen downstairs in the night. He got up to go to the loo, and instead of going left to the bathroom, he'd gone right and fallen down the stairs. Luckily, there's a dog leg in the stairs, so he fell down 5 stairs one way and then 5 stairs another way, but he managed to break his hip. He was admitted to hospital. So I went up to Chester and saw him, and it turned out that he was found to be in heart failure, so they couldn't operate on him. They had to sort out the heart failure first, which they did very efficiently. And then actually a bit too efficiently, because they made him a bit dehydrated, trying to get rid of the excess fluid, and that affected his kidneys. So they had to sort that out. Anyway, that quite commonly happens. And he had his operation, his hip was fixed, and then he became delirious. And it wasn't quite clear what was going on. He always hated being ill, and hated illness, and found it very sort of threatening and worrying, whatever. And so he's in hospital. And then he had a gastrointestinal bleed. He bled from his stomach, probably a stress ulcer. And so he had a sequence of events. He had the fall with the fracture, the heart failure, the kidney problems, which were fixed, the operation, the stomach bleed, and sort of each week something new happened. And then he recovered from the bleed from the stomach, and it was settling down. Then he developed pneumonia, and he was transferred to ICU, and he died. And this all happened over 7 weeks.
Oh my goodness.
It's a sort of a characteristic pattern, really, that we knew he had heart problems, and he'd had an angiogram of 2 or 3 years before, after he fainted in a swimming pool. And so he knew he had heart problems, but it wasn't obvious to me that that his heart problems had become out of control, that he developed heart failure, i.e. fluid on the lungs. He'd always been fairly healthy and played sports in his youth. And I mean, I felt terrible that I used to speak to him on the phone from time to time, not every day, but from time relatively regularly, I would say. But to find out that my own father had been admitted to hospital with a condition that, in theory, I should have been able to diagnose was sort of quite thought-provoking, to put it mildly. And but then the characteristic sort of domino effect of an older person who, on the face of it, when dressed, seemed like a healthy, active man, but when lying on a hospital bed in a gown and looking very frail, was actually not quite as robust internally as he looked externally. And so that as each domino fell, knocking on the next one, it became sort of the inevitable happened. And just to preface that, one of my geriatrician colleagues had, when I mentioned that my father had been admitted with a broken hip, they said, well, something along the lines of, you do know the statistics are that 1 person in 3 who breaks their hip will be dead within 6 months. And I mean, that's just a balls to, a fact. Yeah. And they were right. And we know that roughly when people break their hips, a third of them will go back to living independently. A third will end up having lived in some sort of care facility, care home, and a third will be dead within 6 months or a year. So it's not a trivial matter. I mean, broken hips are relatively easily fixed. The mechanics are the easy bit, and hip operations, fixing fractured hips or replacing hips, are one of the sort of best operations that you can have, in the sense that they're very predictable. The complication rate is relatively low comparatively, and the outcomes are relatively good. And I'm an incorrigible optimist. So I hoped he'd be in the first, in the third that do well, but that was not to be. And it wasn't difficult for me to accept, because I see it every day in my own practice. I mean, except cognitively, emotionally, it's slightly differently. But in the end, he hated illness in the hospital and sort of not being able to do his thing. So it was a blessed release for him. But then that precipitated the next geriatric sort of pearl, if you like, which is the idea, the concept of revealed dependency. Because it wasn't until after he was in hospital, and I was going regularly to visit him and stayed with my mother in the family house. And we were driving, if you know Chester, there's an oldie bridge, goes over the river by the weir. And we were going down to the oldie bridge. She was driving, and she pointed to some trees just by the in a sort of tiny little park before the bridge, and she said, "Aren't those lovely?" And she couldn't get the word out. And I said, "Do you mean trees?" "Yeah, yes." And I sort of thought, and this is a woman who had taught English, College for Education, and her go-to recreation was doing word search puzzles. She always had a little word search book in a handbag. So she was stuck waiting for anything. She was busy doing word searches. And so over that and subsequent visits, I sort of observed carefully, and then I checked, and it became apparent to me that she had a form of dysphasia, i.e. inability to get words out. And commonly in a dominant in a right-handed person, which is the majority of the population, the speech center is in the other side of the brain. So in a right-handed person, the speech center is in the left side of the brain, in the temporal and frontal lobes, sort of here and here. And it struck me that there was something not quite right. So I asked her various tests to check, tell me 5 different animals or something, or names of, and it became apparent to me as I observed her and checked her, tested. I didn't test her formally in the sense of doing a full neurological examination, but I looked for clues, and it became obvious that she couldn't get nouns out, that she would use what's called paraphrasia. She would say, "That thing over there, isn't that nice? That green thing over there behind the other thing." And she would avoid using nouns or not use nouns. And anyway, to cut a long story short, it turned out I did some reading, and I thought it hadn't happened suddenly. She had everything else the rest of her life was working perfectly normally. She was always a very organized person. She had a file of facts, and each day she'd bring forward all the to-dos and manage a diary, and she was driving around doing the shopping, running the home, visiting her husband in hospital and doing everything for him. And anyway, to cut a long story short, it turned out that she had primary progressive aphasia, which is a form of dementia, a form of, if you like, Alzheimer's disease, but it affects the language part of the brain initially, preferentially. And that's the bit that starts deteriorating, and then the rest follows later. And so over the following 2 years of her life, the remaining 2 years of her life, she actually had a heart problem or some other medical problems, heart problems, whatever. Her ability to manage the house for the first year that she was alone was unchanged. Despite having, I got her referred to the memory, asked the GP to refer to the memory clinic, which he did, and they confirmed the suspicion that it was primary progressive aphasia. And as a quirk, I've said all right-handed people have their speech in the left side of the brain. 90% of left-handed people also have their speech on the left side of the brain. So in the vast majority of people, the speech center is on the left side of the brain. And in a small percentage of left-handed people, it's on the other side, on the right side of the brain. And I asked the memory people if they do an MRI scan to check whether her speech center, and it turned out she was in the minority who had the speech center damage, or speech center on the other side of the damage was evident on the other side of the brain. So I like to think that she was appropriately anomalous as a member of a medical family. Anyway, she gradually deteriorated over the following over the 2 years from the time my father died. I mean, initially she cleared out all his clothes, she got everything organized, she was running the house perfectly well, but it became apparent that she was not coping, and food was getting left in the fridge and things. So we ended up getting carers. And the social services, or at least the memory clinic, tried to get carers set up. And when the first time they came to visit, she said, "Thank you, but I don't need you. I don't want you to come in. Thank you very much indeed." And she was capacitous to make that decision, in the sense that she was running a house perfectly well, and she was always a very independent person, and in general, thought she could do things better than anybody else, and often could. And so just got on with it. So it was sort of fascinating to see her assert her rights, as it were. But then as things progressed, and it became apparent that she wasn't quite so able to make considered judgments, and, for example, wasn't making good judgments about whether food was edible, and having been left after a period of time or whatever. And my sister and I got in a live-in carer, and we were very apprehensive because of the sort of fairly dominant doer sort of personality, rather than wanting to be wait on hand and foot type. We worried whether this would be accepted or not. Anyway, luckily, the first time the first carer came down, we all went out for an Indian meal in the Indian restaurant where she used to go after church each Sunday. That was her tradition, and everybody got on with each other, and she accepted this person living in the house with her for several weeks, and there was a small rota of a few of them. And so I mean, it was interesting seeing from the inside what it was like coping with someone who was living with dementia and how it affected them, but knowing that this was only how this type of dementia affected this person in this context, and that the solutions that worked for her at whichever time it was may or may not work for anyone else in their situation. So I took a lot of lessons from that about, and also seeing how often elephantinely lumbering the bureaucracy was to do with a lot of things, social service, the legal things. My sister and I got legal lasting power of attorney. I think it was just after it had changed. to the newer system, the current system, as I recall. And so taking a step back, my work in dementia was greatly influenced by my own experiences with my mother, but also my experiences with my mother were greatly influenced by my experiences with a lot of patients I had. I became the clinical lead for dementia in our hospital around about the same time, I think, that my mother developed or was diagnosed. I can't remember exactly which way around it was, but I know that I'd been asked if I'd be willing to do it before that. And I said no. I found the thought too daunting because I thought dementia is very complicated and there's lots of neurology and learning about how the brain works and how it goes wrong, and the brain's very complicated and I'm a very simple person, and I thought it was a bit too much work. But then once I'd been introduced to the fact that dementia is just someone not being able to live their own life in the way they normally used to, sometimes being aware of that fact and sometimes not being aware of that fact themselves, and that managing people with dementia wasn't about complicated, expensive treatments and pills and interventions. It was about simple, practical things to help a fellow human being live a life safely and with quality, and to their standards and preferences and priorities, not mine, except where the law insisted otherwise. And it's fascinating, really, how, as a doctor, it sort of became increasingly apparent to me that a lot of healthcare professionals who aren't doctors are very loath to take risks, or to allow their patients to take risks, and they'll say, oh, you better do this or you better not do that because X, Y, Z might happen, rather than saying, well, if you do this, there's X% chance of that happening and Y% chance of that happening, benefit and risk. And if you do the other, there's A% chance of risk and B% chance. What are your preferences? And it's interesting that if you go to see a financial advisor, they'll do a financial risk appetite analysis on you. Are you the sort of person that just wants to put all your money in premium bonds and knowing that you'll get a certain amount every few weeks or whatever, or do you want to get government bond? Well, you may get a certain amount every week, and you might get a big win. Do you want to just buy some government bonds and get a definite small amount every week, or do you want to buy shares and maybe make millions on the stock market, or go bankrupt if you invest in tulips or Jeff Bezos at the wrong time of history? Anyway, but we don't really do that for our patients. We do it tacitly, I suppose. But I think there's still a lot of paternalism where healthcare professionals project their own risk appetite onto their patients and think, well, if this were my mum or my dad or me, what would they or I do? And my mum and my dad and this patient, or I and this patient, may have very, very different views on life. And I was used to luckily, there are only a few of us here, so I can reveal that I'm a closet anarchist, and no one else will know. But I used to take great delight in empowering patients to do things that they wanted to do that they knew might be risky. For example, a little old lady who was a bit unsteady on her feet, and who wanted to go and live by herself at home without care, knowing that there was a significant chance she might fall over and break her hip and might die as a result if she wasn't found. And if I'd said that to her explicitly, and she was cognitively intact, but just physically frail, she said, well, I don't mind. I want to be in my own home. If I fall over and die, I fall over and die. And if I die in my own home, that's people of that generation. Generally, they were used to people dying in their own homes throughout most of their life until the current generation, maybe or two. And so that was not a big thing for them. Whereas a social worker or and I'm not believe me, I'm not dismissing social workers, because they have an impossible job a lot of the time, as we've just seen in the recent awful case of the young boy. But if they get it right, no one notices. If they get it wrong, everyone pounces on them, and because people pounce on them, there's a tendency to err on the side of caution. and which is true of a lot of healthcare professionals, I'm sure. But as I actually enjoyed the fact that as a doctor, and the privilege, I was given the privilege of being able to allow people to make decisions that other people were frightened of or didn't really felt uncomfortable with, because a person might suffer as a result. But if a person makes an option where they know they might suffer, and they take that risk and they do suffer, and they shrug their shoulders and say, well, I made this choice and I'm glad I did, or I regret I did, but I would have made the same choice again, and because that's how I like things, then I see that as a major, as a sort of massive plus.
I think that's a huge part, isn't it? For as a lawyer, sitting there going, it's just the Mental Capacity Act. It's that sort of assumption that people have capacity until demonstrated otherwise, and people must be allowed to make unwise decisions. And if they are capacitous, then they can be as unwise as they wish. And it's that sort of dialogue we will have, or I will certainly have, with people when we're talking about powers of attorney and enacting them. And we go through the right, you're choosing your attorneys, make sure that they understand what the role is, but also now you are an attorney, this is what you can and can't do. And you might be very frustrated with your parent. They might be doing things that you think are utterly foolhardy. And I sort of talk about personal experiences. I mean, absolutely, I've sort of got elderly family members, and I just go, do you know, I can't look. I was looking out my window the other day, and my 88-year-old neighbour was up a ladder pollarding a tree, and I went, do you know what? Good luck to him. If it was my father, I'd be slightly concerned, but he's obviously happy, so I'll just leave him be. And it is that tension, though, isn't it? That sort of paternalism of the family, often, of make it better and keep them protected and safe, with actually you can go and live a life that might be dangerous.
And in fact, there's a whole wealth of evidence that doing what you want to do is good for your health. And having a positive thing and having a reason for living and wanting to do X, Y, and Z keeps people going. That people don't die randomly; they die. There's clustering around significant dates and significant events. So people will die just after Christmas, or just on or after Christmas, or just on or after a birthday, or whatever. Not everybody, but people, as I say, it doesn't happen randomly. People will hold on for certain events. And if the human spirit is an amazing thing. And I over the course of my career in medicine, the number of very frail, old, or sometimes not old, but usually old patients who had some serious illness, and they were in a hospital bed, not eating or drinking, maybe having had a major stroke or heart problems or whatever, or cancer, and they would survive for days and days and days, where there was nothing one could do to make them better. One knew they were going to die, and it was just a question of waiting for nature to take its course, obviously easing any distress or alleviating any problems along the way. But the human body, well, not just human, but the body's sort of primeval desire to survive is just incredible, really. And I in my more recent work, and since I retired, I've started doing medical legal reports for survivors of human rights abuses and torture and so forth, trafficking, what people go through and survive. When I was in Norfolk, the Norfolk Regiment was one of the regiments in Singapore when it fell to the Japanese in World War II. So a lot of Far Eastern prisoners of war, the Burma Railway and all that. And when you read accounts or when I listened to what they've been through, I mean, one of the privileges of being a geriatrician was being very allowed into the inner space, as it were, of people who'd lived through one and sometimes two world wars, and had incredible, in the literal sense of the word, experiences. Some of them terrifying, some of them amazing. And just knowing what the human body can put up with, and seeing how the human body, how the human bodies will just not give up, even against all the odds, is I suppose is one of the positive things in my career. That although there's a lot, we're particularly with social media now, we're and with the internet sort of global awareness, we know if something terrible happens anywhere in the world, pardon me, we're often, we'll know about it very quickly. And to counteract that tendency, I always bring up the book Factfulness by Hans Rosling, which is all about getting high quality evidence about what actually is going on in the world. And when you examine it, the world is actually getting better. The average income is going up, the average number of children per woman is going down, the number of people below the poverty line is going down. All the curves globally, on average, are moving in the right direction. But there are it's still very heterogeneous. So there's still pockets of awful things happening in places, and lots of people suffering. And one has to try and keep things in balance. Unfortunately, newspapers don't make any money out of the good news. They only make money out of the bad, the frightening stuff. So we have this cognitive bias that the world is a terrible place, because that's all the mainstream media and a lot of the social media, which depend on traffic, or the former depend on sales, the latter depend on traffic, and sales and traffic are enhanced by fear and alarm and death and despair. So we have to try and keep balanced amongst all of that.
So at the beginning of this, before we started, you were talking about powers of attorney, and you're having I think fun and games technical term.
Well, okay, yeah, yes.
I'm intrigued.
Right. Well, I was coming into this chat feeling very proud of myself, self-satisfied, which I apologize, that after years of talking about it, my wife and I had eventually gone through the process of going through all the documents for health and welfare, property and finance for both of us. And on the 29th of November, but luckily we've got a GP colleague who lives a few doors down who was able to act as the, whatever it's called, the
certificate provider.
Yes, thank you. I'm not very good on jargon. Anyway, so we were able to get it done ourselves, and I mean, I found it quite challenging working through. We did it online, and I have to say that the online thing is actually very good. But even though it's done as simply as possible, the process is of its nature quite complicated. Working out who's who in the personae, dramatis personae, and because when you're both acting as the attorney for each other, then trying to work out who's who in each of the documents is not always easy. Anyway, I worked through all of those logically. So we ended up, each one's a 20-page form. So we ended up with 80 sheets of paper, which I duly put very carefully in a envelope, sealed it up, and sent it off on the 29th of November, signed for, and thought I can go and be very self-satisfied and say, I can tell everybody else to go and get their lasting power of attorney. And this morning in the post, we got an A4 envelope saying this became open in the post or something. I opened it, and it just contained roughly half of those things. No. Half the forms, some of mine, and with no other explanation. So I went and looked on the tracker thing on the when I'd posted it, and it said all it had was registered but having been accepted by the post office, nothing after that. So
frustrating.
Well, that's putting it mildly, really. And I mean, there are various things. Firstly, it took an awful lot of effort to get that done. We're going to have to repeat the whole thing because, although we scanned and got photocopies of all the original documents we sent through, then we have to send originals. So we have to do it again. Going to have to get someone else to come and sign everything again. And getting his wife was witness to the various signatures, so it was all sort of pucker. And because it wasn't clear. Well, at least I presume that the what's he called again? The guarantor.
Oh, the certificate provider.
that the provider could actually witness the signatures. It didn't say he wasn't. I mean, the certificate provider is not explicitly excluded from being a witness, but I thought it might look dodgy if he was doing both roles. So I got his wife to do the witnessing, and that took, I don't know, because they were having to sign 3 different pages and 4 sets of things each, I think. Anyway. So there's having to get it all done again. It's a pain, because I thought I'm allergic to bureaucracy. I love dealing with people. I hate dealing with paper, and that's another. I mean, thereby hangs various other tales. But anyway, so the thought of having to do that whole thing again, I'm struggling to remain.
Mr. Enthusiasm.
well, no, to remain polite. I'm so furious about it. But then a lot of very personal information has been, is floating around somewhere, and I don't know what redress I have. I mean, I'll get the money back from the post for posting it, but that's the least of my worries, really. And I don't know whether I think I'll have to see a solicitor to see whether I can take any further and make a claim for anything else. But anyway. So anyway, I've got that off my chest, so I feel a bit better now. But I'm going to have to start again.
But as you say, I mean, those forms are incredibly long-winded, and I know sort of all the reasons that they were created in the way they were created was done for the best of intentions, and we are where we are with that, and certainly we are in a process at the moment as lawyers in looking at simplifying, or the government's looking at simplifying powers of attorney and what is and isn't involved. And as lawyers, we're getting slightly twitchy, because we sort of go, well, a lot of the reasons those things are in there is they're protecting people who will become vulnerable. If you take away a lot of those safeguards, we're going to have a lot of difficulties down the line. And as you say, for someone with your background and your knowledge to sit there and go, I've done my 80 pages and I've got to do them again. They are important, but it is something that we are very aware of. They sort of blindly say, "Well, get your power of attorney sorted." It is quite a big thing, and for people who don't want to think about their mortality or lack of capacity, real or potential, it is a real struggle and a burden to get that over the line. But I'm conscious we are coming to the end of our hour. So anybody have any questions they would like to throw out there? Anything at all? We shall, happily take any queries. Tish, hello.
Hi, hello. Hi, everyone. No, I don't have any questions as such, but I did want to say how much I enjoyed that medical and personal evaluation. So I'm really grateful to you for doing that. And the bit I think that resonates as well is where Heledd mentioned about the best interest principle in the in terms of mental capacity, how you identified a real key area with that, which is people's attitude to risk. Because Heledd may agree, one of the difficulties of dealing with a diverse range of professionals in terms of making decisions about older people is that although you're looking at what the older person, it would be in their best interest, it's very hard for people not to bring their own subjective determination as to what is in their best interest. And the example you gave of the lady going home on her own would definitely, to a social worker, trigger lots of concerns. And we're not talking about where people might potentially lack capacity, even where they do. The Capacity Act does specifically say that just because they make an unwise decision doesn't mean that they don't have the capacity to do so. Unfortunately, that isn't always widely understood by people who, in their very best interests, do want to protect them. And I think in practice, I think you've identified that really well about how that's difficult for people seeing the same situation at different angles. I mean, I live on a farm in the middle of nowhere. Everybody that I know's attitude to risk is very high. I see a lady in her 80s out riding her horse all the time, and she frequently tells me the statistics for people that if they break their hip, and for people that perhaps should give up gracefully and take up knitting, but she doesn't want to do that. So I found that really helpful, and it's very helpful for us when we have to look at what to do in terms of making the best decisions, helping people to come to that right decision.
And that goes right back to knowing the other individual, or knowing each other. Because if I mean, I remember in the good old days, I'll get off my other soapbox, when your bank manager knew you and you knew your bank manager. I remember being taken at the age of 16 to my father's bank and being introduced to the manager to open my account, and you know, the manager knew my parents were sort of reasonable pillars of the local community or whatever, and there was trust there. And you stayed with, you were loyal to your bank because they gave you good service, and they gave you good service which earned your loyalty. And now I'm not saying things are worse in general. I mean, in many ways things are better, but that loss of continuity of personal connection and of trust means you have to have a 20-page document rather than me saying to you, I trust you to make sure you know me well enough. You know that I wouldn't want to be put on a life support machine if I was going to end up as a mangled wreck who couldn't enjoy life or couldn't joke with people and enjoy myself. And you know what sort of things I like doing. So, you know, you'd be able to make that decision. Now I have to write out in advance what my wishes are. And if I haven't specified to the letter, or if I specified something that doesn't quite match my current situation in the hospital, then it doesn't apply, because the text says this, but the situation is that, and they're slightly different, so it doesn't apply. So we got, you know, our advanced directive is null and void in this situation. And it's trouble is that there's the danger of the trying to make it perfect being the enemy of trying to make it good.
Exactly that.
Absolutely, I couldn't agree more. It's such a struggle we have, isn't it, that, you know, doing this work, that we are doing our level best to sort of empower people to be in a strong position. I often say, it's like, look, it's part of your toolkit. You know, you hope you never need it, but if it's there, you know, let's have that toolkit. And who's on your side, who's in your team, you know. So your attorneys are in your team, hopefully your doctor, your advisors are in your team. And for us, it's about planning rather than crisis management, and we try and do our very best to put people in a strong position, as strong as they can be, because, you know, when that broken hip, as you say, it often is a broken hip, it's that trigger event for so much else now, that it's really nice to be able to say to people, look, we've given you the best chance of being able to have sensible dialogue. But it's hard, as you say. So when you've got people's imposing their own views on what is best interests, that's, for me, utterly fascinating, as how, you know, and that very human nature and human condition of, well, I know best.
And I think, as Heledd said, you know, everyone is doing it with the best intentions in the world. You know, the complexity of the LPA form, for example, is meant to be for good intentions, but as you say, it makes it unnecessarily long in some ways, and no matter what you put in, it will not cover everything. I mean, you know, going back to, you know, how we're working with professionals, the Law Society and the Financial Conduct Authority, they all ask, Sisters Regulatory Authority, they all ask that you know your client, and there's quite a lot of fact finding you have to do. But the reality of that is that the fact finding that you do that meets compliance is never the kind of fact finding that makes you able to answer a question that's very subjective about a preference or a lifestyle choice. And that, I mean, I work, you know, I'm involved in SOLA, the Society of Later Life Advisors. Most people know we work very closely with people like Heledd, a solicitor for the elderly, trying to ensure that the clients that they have do have that continuity and that trust with people. But there's a mixed range of professionals deal with older people.
Well, what you just said reminds me that one of the key, one of the principles that I carry around with me is the McNamara fallacy, which is the McNamara fallacy is making the easily countable or easily measurable important rather than making the important easily measurable. And so and Robert McNamara was the Secretary for Defense during the Vietnam War, and their metric was the number of dead Viet Cong. What they couldn't measure was the morale and the psychology of the living North Vietnamese. And they killed, the more determined the remainder were not to give in. And he mentioned that in sort of reflecting on the war later. But so if we measure the wrong things, we get the wrong results, or we don't get the right results. And you can't, with a few questions, build up the same understanding and trust that you can from having known someone for 20 years and chatted with them on and off and seen them through life events, and seen how they reacted to life events or reacted to other people's life events. And for all the sort of instant gratification and instant accessibility of our online technological life now, it's the human contact, human relationship is still a key thing. And you know, yes, we can get a lot done. There's the other thing, the Pareto principle. With 20% of the effort, you can get 80% of the job done. But getting the final 20% of the job done takes 80% of the effort. And so with the sort of this immediate accessible life, we can get a lot of stuff done, sort of 80% a lot of stuff done very well, but it's the final 20% that often makes the difference and can be critical, as you've just been suggesting, Trish. So I don't know what the right answer is. I've seen so many benefits from the internet, and I can remember when the idea that you could look up any drug or any condition immediately on your desk while the patient was there and get some basic information about it was just a science fiction fantasy. You had to go to the library or request something or pay somebody to look something up, and then you get the answer the next day if you were lucky. We've been swamped with information, but there's a big difference. There are facts, and there is information where that's facts in context, and there's knowledge where that contextualized information is organized, if you like. But the hierarchy above that is wisdom, and we haven't really achieved that. I mean, technology has given a lot of information and to some extent managing knowledge. But I suppose you could say that artificial intelligence, if it's done right, may end up mimicking quite a lot of wisdom. But a person who's been steeped in something for a long time but has still got their feet on the ground and in touch with reality and can find a compromise between their sort of academic interest and the reality of real life, is someone well worth knowing if you want to know about a particular topic. And Wikipedia is brilliant, but it's not doesn't give all the answers by any means.
And I just want to say, I mean, absolutely. I mean, listening to you today has been absolutely fascinating from that sort of, your professional background, your personal background, all that interaction, all that stuff you've learned all on your travels. It is very hard to distill that and pop it on a web page. But like you, learning is great, and the fact you can just look up things and find that information really quickly is a huge help, isn't it? But ultimately, I think as humans, we have to be able to impart that information to people in a way that makes sense to them, and that's the skill set, isn't it? I think. And but I would just like to say we are out of time. It's been absolutely wonderful sort of talking to you, and thank you ever so much. And I hope that your power of attorney saga goes as smoothly as it can. Maybe a trip to Birmingham, post it through the door.
Oh yeah, I'll certainly take much greater care with getting it delivered. Anyway, well, the dress rehearsal went fine. Let's hope.
Excellent. Well, thank you ever so much. It's been wonderful, and I hope that you have a lovely Christmas as we are sort of rapidly approaching that. And thank you ever so much for your time today.
That's very kind of you, and thank you.
Okay, thank you. Bye-bye.
Bye.